Okay. Just one housekeeping note. It was pointed out to me by one of the audience members that there were a few slides, I think specifically on prasugrel dosing in the first talk that are not in your handout. And as I'm sure you realize, that the handout was submitted a long time ago, and I added some slides before, I guess last night I added them. Anyway, Dr. Perillo assured me that the updated talks with all the slides are available on the website. So tonight they will be uploaded, and then should have exactly every slide that I present available to you. Okay. Yeah, it's not doing anything. Okay. I guess the remote isn't working. Okay, so this is the first slide from the first talk. So now we're on the left-hand side of the slide. We're talking about patients that present with chest discomfort at rest without ST segment elevation. Generally speaking, the studies have shown that these are non-total occlusions of the coronary artery rather than the total occlusion as in patients with ST segment elevation. When patients present without ST segment elevation, they may so-called rule out. Their troponin may be negative or normal. We would call those patients with unstable angina if they have coronary disease, or they may rule in with an elevated troponin. And in that case, they may be called patients with a non-ST segment elevation MI. Most of them will not evolve Q waves, but as I spoke about this morning, if they have a large enough infarct, Q waves may evolve. Just one slide on the pathophysiology. In patients with non-ST segment elevation acute coronary syndrome, the elevated troponin is associated with a number of factors. One is there's an increased frequency of impaired flow, meaning less than 2 or less, 3 being normal. And the incidence is about 40% abnormal flow in someone with an elevated troponin versus only 25% with a normal troponin. There's an increased frequency of coronary thrombus when angioscopy is done. This is an investigative tool, not done clinically. But about 86% of patients were found to have thrombi when the troponin was elevated versus only about a third when the troponin was normal. So you can consider a troponin a marker of thrombosis. Elevated troponin is associated with worse LV function and higher mortality. And it's useful to us because it's an indicator of enhanced treatment benefit from a number of things, including low molecular weight heparin, 2B3A inhibitor, and an early invasive strategy. So it's a good guide to therapy. Just want to remind you that there is a differential diagnosis to chest pain. The 3 life-threatening causes that I like to remind our fellows about are acute coronary syndrome, pulmonary embolus, and aortic dissection, and not to forget about these 2. Pulmonary embolus can be associated with elevated troponin, so it's easy to miss unless you think about it. Aortic dissection can be overlooked because it can be associated with an acute MI, usually inferior MI due to occlusion of the right coronary artery. Obviously, this is a contraindication to lytic therapy. There are, of course, benign causes of chest pain that you have to think about. Pericarditis is problematic because it can be associated with both elevated troponin when there's a myocarditis component, and ST segment elevation, of course, occurs in pericarditis. And in fact, I have seen patients who had pericarditis who received lytic therapy. One of those patients was actually a physician. Gastrointestinal causes should be easy to distinguish. They are not associated with elevated troponin ordinarily or ST changes. And of course, there's musculoskeletal and neurologic causes of chest pain. It was mentioned earlier today that there are a number of causes of elevated troponin that should not be considered a myocardial infarction. There's demand ischemia, as in sepsis or the systemic inflammatory response syndrome, hypotension or hypovolemia. Sometimes tachycardia, such as atrial fibrillation with a rapid ventricular rate, can be associated with an elevated troponin. And there are reports that patients with left ventricular hypertrophy alone may have an elevated troponin. Myocardial strain, quote unquote, may result in elevated troponin in cases of heart failure, pulmonary embolism. Specifically, when the troponin is elevated in pulmonary embolism, as I'm sure you'll hear later this week, that's an indicator of right ventricular dysfunction, and it's a high-risk marker. Chronic renal insufficiency is a problem for us. We have patients who have chronic elevations of their troponin, and we often don't know what to make of that when their baseline troponin is elevated and they come in with chest pain. Often they end up having a cath to figure out what's going on. Certainly myocardial ischemia is a cause of elevated troponin. It may not be thrombotic occlusion. It could occur in the case of coronary spasm that's prolonged. There are reports of intracranial hemorrhage or stroke causing troponin elevation. Some pathomimetic agents such as cocaine can cause an elevated troponin that comes from the myocardium. And finally, a direct myocardial damage, such as due to a contusion, say an auto accident, cardioversion of an arrhythmia, some infiltrative disorders or chemotherapies that are cardiotoxic. I mentioned myocarditis and myocardial transplants that are being rejected. So the guidelines that we're working with now for the non-ST segment elevation acute coronary syndromes were written in 2007, so they're fairly recent, published in Circulation in the Journal American College of Cardiology. For immediate management, it's emphasized that aspirin should be given. The dose can be anywhere from 162 to 325. And note that it's recommended to chew the aspirin for better absorption. They also recommend giving sublingual nitroglycerin to a maximum of 3 doses every 5 minutes. Risk stratification begins with the electrocardiogram in the emergency department with a goal of getting that ECG obtained and interpreted within 10 minutes of arrival. It's important to repeat the ECG if the initial ECG is not diagnostic and the patient remains symptomatic and there's a high suspicion of an acute coronary syndrome. And it's recommended that it should be repeated within 15 to 30 minutes. Because if you wait too long, you might miss a patient with an acute MI. So here's my first question. A 54-year-old man presented to the emergency department in the morning with a history of intermittent chest pain for 2 days. He's on no meds. His exam is unremarkable. His ECG is shown here. So your choices are a resting sestamibi scan, a nuclear stress test, an intravenous fibrinolytic drug, or an urgent cardiac catheterization. This is different than this. This ECG is, I don't know where that came from. This is the right ECG. How does that happen? Yeah, well, I saw the difference even from here. All right, so 60% of you recommended a cath. That would be correct. Lytic drug is not indicated, as I will show in patients without ST elevation. You might have been looking at the ECG over here that did show ST elevation. We would not do a stress test with someone who had resting ST segment depression during pain. Nor would we do a sestamibi scan. So the important feature in this electrocardiogram is the prominent ST segment depressions at rest during pain. So this is a slide that was published in 1994, and in this study, what I want you to focus on are these patients that had ST segment depression on the electrocardiogram. And in this analysis of almost 60,000 patients in 9 randomized trials of lytic therapy for patients with chest pain suspected to be acute MI, 6 of the trials included patients without ST segment elevation on the electrocardiogram, and there were over 4,000 patients that had ST depression. And you can see here that there was actually an adverse effect on outcome in patients with ST depression. You can see here there was a beneficial effect in patients with a new bundle branch block, patients with anterior MI, and some benefit in patients with inferior MI, but an adverse effect in patients with ST depression. And this is a class 3 indication, therefore, for lytic therapy. Intravenous lytic therapy is not indicated in patients without acute ST segment elevation, a true posterior MI, or a presumed new left bundle branch block. Now, of course, aspirin has been shown in numerous trials, shown here, to be beneficial. And I'm showing this slide primarily to show you that the dose in the 4 trials varied. So in these 4 trials, the red bars are the placebo group, the yellow bars are the aspirin group, and the endpoint here is death or myocardial infarction. You can see there's about a 50% reduction in the risk of death or MI in patients who were treated with aspirin compared to placebo in these randomized trials. And the benefit was observed at a dose as low as 75 milligrams. And I always call this the European dose of aspirin, in the sense that this is not commonly used in the U.S., but was found in a European study to be efficacious. Now, there is a study that I'd like to quote here, the CURE trial, in which patients were randomized to aspirin or the combination of aspirin and clopidogrel. And these are patients with acute coronary syndrome. And what you see here in the bars are 3 groups of patients. Patients that were treated with aspirin in a dose of less than 100 milligrams, and then patients who were treated with higher doses. And in this study, aspirin was left at the discretion of the physician taking care of the patient, so the dose of aspirin was not mandated. And you can see here there was no increment benefit in terms of the incidence of death, MI, and stroke as the dose of aspirin was increased, whether the patients were treated with aspirin alone or the combination of aspirin and clopidogrel. There was no benefit of increasing the dose of aspirin. There was, however, an adverse effect of increasing the dose of aspirin. And you can see here, for aspirin alone, the risk of bleeding, major bleeding, increased from 1.9% to 3.7%. For aspirin and the combination of clopidogrel and aspirin, from 3% to 4.9% as the dose of aspirin increases. So there is now one randomized trial looking at 2 different doses of aspirin in patients with acute coronary syndrome. I alluded to this trial in my earlier talk, the current OASIS 7 trial, not published yet, but the data have been presented. Over 25,000 patients with acute coronary syndrome, 70% of them had non-ST segment elevation MI or unstable angina. They were managed invasively. And they were randomized in a 2x2 factorial design to either high-dose aspirin, 300 to 325 a day, versus low-dose aspirin, 75 to 100 a day. And as I'll show you later, they were also randomized to 2 different doses of clopidogrel. The bottom line, no significant difference in the efficacy, and in this case, we're bleeding between the high-dose and the low-dose aspirin. And so the new guidelines have somewhat lowered the dose of aspirin compared to previous guidelines. I want to talk now about the platelet P2Y12 receptor antagonists. We used to refer to this group of drugs as thienopyridines, and in fact, ticlopidine, clopidogrel, and prasugrel are thienopyridines. But there are now 2 more drugs and additional drugs coming, which are not thienopyridines, which do inhibit the same receptor, the P2Y12, which is the predominant receptor involved in ADP-stimulated platelet activation. This trial you probably have heard of, although it's 9 years old now. It's the CURE trial. And in this trial, patients with acute coronary syndrome were randomized to either placebo plus aspirin or the combination of clopidogrel plus aspirin. And you can see here there's a significant reduction by 20% in the risk of death, MI, or stroke over the period of 1 year. And that's mainly why clopidogrel became part of the pharmacologic treatment of acute coronary syndrome patients. So here's the guideline. Aspirin should be administered as soon as possible after presentation and indefinitely. And clopidogrel, a loading dose followed by a maintenance dose, should be administered in patients who are unable to take aspirin. And as you'll show you, they also recommend the combination. Now, in this paragraph, it's a caveat saying that we don't know what the proper loading dose of clopidogrel should be. And they say, well, 300 at least, maybe you should give more. More is better. They're not sure. So this trial was done to try to answer that question. And again, it's not published, but the other randomization was double-dose clopidogrel, a loading dose of 600 milligrams, and then a maintenance dose of 150 milligrams a day for only a week, and then the usual dose of 75 a day for thereafter, versus a standard dose of 300 milligram loading and 75 milligrams a day. And you could see here that the double dose was better than the standard dose in terms of the risk of death, MI, or stroke at 1 month. There was a 15% reduction. More important to me is the risk of stent thrombosis was reduced by 42%. And this is obviously very important to be able to reduce the number of patients that have a stent thrombosis after an acute coronary syndrome. And so the conclusions from this study are that double-dose clopidogrel significantly reduced the risk of stent thrombosis in major events. Now, it's important for me to point out to you in patients who do not undergo PCI, percutaneous coronary intervention, the double-dose clopidogrel was not significantly different than the standard-dose clopidogrel. And there was a modest excess in bleeding, but no difference in major bleeding, intracranial hemorrhage, fatal bleeds, or CABG-related bleeding. So you can get away with this dose. It's, of course, not FDA approved, and it's not in the guidelines yet. And so for every 1,000 patients with an acute coronary syndrome who underwent PCI, the double dose for 7 days instead of the standard dose prevented an additional 6 MIs and 7 stent thrombosis with 3 severe bleeds, but no increase in fatal bleeding. Excuse me? Oh, okay. Okay. Now, this is a recommendation that I want to point out. They say that in patients with acute coronary syndrome with a history of GI bleeding, when aspirin and clopidogrel are administered alone or in combination, drugs to minimize the risk of recurrent GI bleeding, for example, proton pump inhibitors, should be prescribed, and that's a class 1 indication. And that's a problem because some proton pump inhibitors are metabolized by the cytochrome enzyme CYP-C19. Omeprazole specifically inhibits CYP2C19 activity, and I'll show you why that's a problem. Co-administration of omeprazole with dual antiplatelet therapy has been associated with higher platelet reactivity because of the fact that it inhibits this enzyme. So in November, during the American Heart Association meeting, the FDA issued an alert and updated the label of clopidogrel. And they said, FDA is alerting the public to new safety information concerning an interaction between clopidogrel and omeprazole. New data show that when clopidogrel and omeprazole are taken together, the effectiveness of clopidogrel is reduced. Now, that was based on, I think in part, this trial. It's not really a trial. It's really a post hoc analysis of patients who were taking medications after discharge from VA hospitals. It was a large trial. It was 5,000 patients. And there are 4 curves. There's clopidogrel alone, clopidogrel without a PPI, clopidogrel with a PPI, a PPI without clopidogrel, and then neither drug. And you can see here that there seemed to be an adverse effect of combining PPI with clopidogrel. However, that was not confirmed in a subsequent study that was published in Lancet. And in this trial, you can see here 2 overlapping curves up here. These are clopidogrel with or without PPI, and this is prasugrel, a different thionyl-pyridine, with or without PPI. And there was no difference or no effect of PPI on the incidence of death, MI, or stroke. So this is an opinion paper that was published in the American Journal of Gastroenterology this year. Charlie Hennekins was one of the co-authors, and he said, as the presence of PPIs in clopidogrel in plasma is short-lived, separation by 12 to 20 hours should, in theory, prevent competitive inhibition of CYP metabolism and minimize any potential, though unproven, clinical interaction. And PPI may be given before breakfast and clopidogrel at bedtime, or PPI may be taken before dinner and clopidogrel at lunchtime. So number one, we're not sure if this is really a clinically important interaction. And number two, there seems to be an easy way to avoid it. So more importantly, there are genetic problems with clopidogrel that are not easily avoided. There is inter-individual variability in clopidogrel responsiveness that may result from functional variations in the genes that encode the hepatic cytochrome P450 enzymes that are involved in the formation of active metabolites of clopidogrel. And the focus right now is on this mutant allele, the CYP2C19.2 mutant allele, which is a non-functional variant of the active allele and is present in the heterozygous state in 20 to 30% of Caucasians and 30 to 45% of African Americans. In patients who receive clopidogrel compared with the functional enzyme, the mutant allele is associated with lower levels of the active metabolite, higher platelet reactivity, and increased risk of clinical events and stent thrombosis. And so here's an example of that. This is a randomized trial that looked at carriers versus non-carriers of the mutant allele, and these are the events over time. It's hard to see here, but I think it's out past a year. And this is the risk of cardiovascular death, MI, or stroke in subjects who received clopidogrel. And you see here that there was a higher event rate in carriers of the mutant allele. And this is the risk of stent thrombosis. This is the carriers of the mutant allele versus the non-carriers. And obviously, the patients here at a higher risk of stent thrombosis. Now, the metabolism of clopidogrel is shown here. And you can see here that this allele, this enzyme, is involved in a two-stage conversion of clopidogrel to the active metabolite. Now, the way that prasugrel in part differs from clopidogrel in that the enzyme is involved in only one of the two stages of formation of the active metabolite. And for that reason, prasugrel appears to be irrelevant to the carrier state, or the carrier state is irrelevant to the impact of prasugrel. And you can see here that the risk of death, MI, or stroke in patients who were treated with prasugrel was the same whether the patients carried the reduced function allele or did not carry the reduced function allele. So it's about as up-to-date as I can get on this. On March 12th, the FDA mandated a boxed warning added to the label for Plavix. And it's extensive, but it says, be aware that some patients may be poor metabolizers of Plavix. They do not effectively convert Plavix to its active form because of this mutant allele, and therefore the effectiveness of Plavix is reduced. It says, be aware that these tests are available to determine a patient's carrier status. Now, the test costs about $500. It's not quickly available. This is not a practical recommendation in my opinion, but I don't work for the government, which I guess I'm grateful for. It says recommendation in the warning is consider use of other antiplatelet medications or alternative dosing strategies for Plavix in patients who have been identified as poor metabolizers. So since we can't test for it, what are our options? I think our options are to give a double dose of clopidogrel, as is the current trial demonstrated is more effective than the standard dose, or to use prasugrel. And that's the state of the art right now. There is no bedside point-of-care testing for the enzyme in question. I want to move on to question 2. Coronary angiography showed multivessel coronary artery disease in the patient that I showed you earlier. There was an 80% stenosis of the left main coronary artery, 70% stenosis of the proximal and mid segments of the left anterior descending, total occlusions of the distal segments of the circumflex and right coronary artery. The patient became pain-free after an intra-aortic balloon pump was inserted. The lab results showed a normal CBC and electrolytes, an elevated glucose, an elevated creatinine. So the question is, which medications are appropriate? All of the options contain aspirin. The first 3 contain clopidogrel. Then you can choose unfractionated heparin and IV nitroglycerin, enoxaparin and IV nitroglycerin, fondaparinux and IV nitroglycerin, aspirin, unfractionated heparin and IV nitroglycerin, or aspirin, abciximab, which is a 2B3A inhibitor, unfractionated heparin and IV nitroglycerin. Okay. So the most popular answer was aspirin, clopidogrel, Infarction, heparin, IV nitroglycerin. The right answer only got a 20% response rate. So what do you need to think about here? This is a complicated question, obviously, intended to be. First of all, the patient has left main stenosis and 3-vessel disease with 2 total occlusions. So most people would recommend bypass surgery. I'm not saying that we never stent the left main coronary artery, but conventional therapy for a patient like this would be bypass surgery, in part because the patient is also diabetic and has multivessel and left main disease. In addition, you have to think about the fact that the patient has renal insufficiency. And so how do those factors affect our choices of medications? Well, you don't want to give clopidogrel because it's going to delay surgery. And the surgeons generally will not operate on a patient until the clopidogrel has been withheld for at least 5 days. You don't want to give a 2B3A inhibitor for the same reason. It hangs around for a long time. Generally speaking, we don't like to give enoxaparin or fondaparinux in patients who undergo surgery because they have a long half-life. So the surgeons will tolerate aspirin, unfractionated heparin, which has a short half-life and can be turned off, and IV nitroglycerin, obviously, to treat the ischemia. Okay. All right. Now, I included a number of slides about anti-ischemic therapy. I don't think there's time to go over them all. There was a question during the break about beta blockers, a couple of questions actually, and it was pointed out to me that even though the guidelines say reactive airway disease is a contraindication, this may not be a reality that patients with reactive airway disease often do tolerate beta blockers. In addition, there was a question about ACE inhibitors and beta blockers, and they are both indicated, but we tend to not use IV beta blockers as we did in the past. So I'm going to skip ahead to the summary slide for anti-ischemic therapy. Those slides are all in your handout. And to say that the guidelines for Class 1 recommendations are bed rest with an ECG monitor, obviously, oxygen, only if the arterial oxygen status is less than 90% or there's respiratory distress or a high risk of hypoxemia. Nitroglycerin is indicated both sublingual and IV. The IV nitroglycerin is indicated for persistent ischemia, heart failure, or hypertension during the first 48 hours, although this has never been shown to improve survival. Oral beta blocker is recommended within 24 hours for patients without heart failure, a low output state, or an increased risk for shock. And those factors I mentioned earlier this morning, but they're here. There. In patients with a recurrent ischemia and a contraindication to a beta blocker and no clinically significant left ventricular dysfunction, meaning no heart failure, it's acceptable to give a non-dihydropyridine calcium antagonist such as verapamil or diltiazem as an alternative to a beta blocker. An ACE inhibitor should be given orally within the first 24 hours in patients with pulmonary congestion or an ejection fraction less than 40%. And ARB is an alternative to an ACE. NSAIDs, except for aspirin, should be discontinued. So here's an angiogram of a patient with an acute coronary syndrome. This is a left anterior descending coronary artery, nearly totally occluded. Here's what we can accomplish by putting a stent in. It's a pretty picture. Question, of course, is do you want that with or without an angioplasty? So how do I answer that question? I'll answer it in a couple of slides, although you could take a half hour to talk about it. This is a slide from TIMI 18, a randomized trial, which stratified the outcomes of patients who were managed in a conservative approach or an invasive approach, and looked at the impact of either troponin elevation or not elevation and ST segment change or not ST segment change. And what they found was there was no impact of an invasive management strategy in patients with a negative troponin or no ST segment change in the baseline ECG. But if the troponin was elevated or the ST segment was depressed, then there was a benefit of invasive therapy. So that's something that's easy to remember. Long term, this is a paper that was published a month or so ago. And what it looked at was a combination of 3 large trials and the 5-year outcome of patients who were managed by routine invasive therapy or selective invasive therapy in patients with acute coronary syndrome. And this is the relative risk of death or MI. And they did was they stratified the patients into 3 terciles, into low-risk patients, intermediate risk, and high risk. And what you see obviously here is that the patients who benefited the most from being managed invasively were the high-risk group. So sicker patients should go to the cath lab. So the guidelines in 2007 said for an initial invasive strategy that an early invasive strategy is indicated in patients who have refractory angina or hemodynamic or electrical instability. But it's also indicated in initially stabilized patients who have an elevated risk for clinical events. Now, what does that mean? So these are the risk factors that would mandate an invasive approach: recurrent ischemia, elevated troponin, new or presumably new ST depression, heart failure, high-risk non-invasive testing, hemodynamic instability, VT, PCI within 6 months, previous bypass surgery. Then there are some clinical risk scores that can be computed, which I don't have time to review. There's a TIMI score, a GRACE score, and patients with left ventricular dysfunction. So this includes a large percentage of the patients with acute coronary syndromes who would fall into the category of invasive management. I'm going to skip this slide because I think I'm running out of time and go to this slide. And so somehow that shouldn't have been in there. Anyway, this is the latest update, 2009, of the guidelines for acute coronary syndromes. So it says reasonable for stabilized patients with a high GRACE score, and that's one of those risk scores, to undergo an early invasive strategy within 12 to 24 hours. For patients not at high risk, an early invasive approach is also reasonable. So basically what they said with the 2A recommendation is that you can cath everybody. So, you know, the invasive cardiologists love that. Now, what about antiplatelet therapy? Patients with definite or likely acute coronary syndrome selected for an invasive approach should receive dual antiplatelet therapy. So aspirin plus either clopidogrel or prasugrel. Now, what about the 2B3 inhibitors? You know, there are 3. There's abciximab, tirofiban, and eptifibatide. The study suggests that they are most beneficial in patients that are troponin positive. I mentioned that earlier. Not beneficial in patients that are troponin negative. Okay. Now, I want to point out that in this study of early versus delayed provisional eptifibatide, they randomized patients who were high risk to either routine early eptifibatide or delayed eptifibatide after they went to the cath lab. And they found that the primary efficacy endpoint, which was death, MI, or urgent revascularization, or the thrombotic bailout to give eptifibatide, was not significantly different. And so there was an increased risk of bleeding. And so based on that, you don't need to give eptifibatide before the patient goes to the cath lab. Now, the other study that I think is interesting to know about is a study that, again, used bivalirudin and compared bivalirudin to unfractionated heparin with a glycoprotein 2B3 inhibitor called the Acuity trial. And this is, again, one of the reasons we like bivalirudin in the cath lab is that there was almost a 50% lower risk of major bleeding in the patients that got bivalirudin compared to the patients that either got unfractionated heparin or enoxaparin plus a glycoprotein 2B3 inhibitor. And so the guidelines now say that for patients in whom an initial invasive strategy is selected, it is reasonable to admit upstream intravenous 2B3 antagonists if bivalirudin is selected as the anticoagulant and at least 300 milligrams of clopidogrel was given. So basically, from our point of view, the easiest thing is give clopidogrel, don't give a 2B3 inhibitor, and give bivalirudin in the cath lab. There's some other guidelines there about 2 anticoagulants, which I'm going to skip. Now, what about patients that are managed conservatively? If you're taking an initial conservative approach, clopidogrel should be given in addition to aspirin. So we don't withhold clopidogrel in patients that are not going to the cath lab. And it's recommended that it be given for at least 1 month and ideally up to 1 year, and that's based on the CURE trial. because in most of those patients in the CURE trial, patients were managed conservatively. Then they talk about anticoagulant therapy in patients that are managed conservatively, meaning not going to the cath lab initially. For patients whom in a conservative strategy selected, regimens using either enoxaparin or fondaparinux have established efficacy. So they like these drugs better than unfractionated heparin if the patient's managed conservatively. And if there's an increase of bleeding, the preference is for fondaparinux because the risk of bleeding is lower. And that's said right here, unless CABG is plain within 24 hours, because it takes a long time for fondaparinux to wear off. It has a long half-life. This is a comparison of all the trials that were comparing enoxaparin with unfractionated heparin in patients with acute coronary syndrome, non-ST segment elevation acute coronary syndrome, over 20,000 patients. And you can see here the risk of 30-day death or MI, risk of transfusion, risk of major bleeding were barely different, and none of these differences were significant, even though there was over 20,000 patients to analyze. So it's really hard to make a firm recommendation that one is better than the other. So what are the doses? The doses of unfractionated heparin in this situation are a loading dose of 60 units per kilo to a maximum of 4,000, and a maintenance infusion of 12 units per kilogram per hour to a maximum of 1,000. Enoxaparin is a loading dose of 30 milligrams per kilogram IV with a maintenance dose of 1 milligram per kilogram sub-Q every 12 hours if the creatinine clearance is greater than 30. But the dose should be reduced to 1 milligram per kilogram every 24 hours if the creatinine clearance is less than 30. Then here's some dosing for integralin and aggrostat. It's in your handout, so I'm going to just quickly go to the middle of the slide. You have to follow the platelet count and stop the drug if there's a significant fall, and the doses of both drugs have to be adjusted for renal insufficiency. I'm going to skip these slides also. These are the chronic antiplatelet therapy slides. So here's what you need to know. Discharge medicines, antiplatelet therapy is aspirin, reduced dose, 75 to 162 milligrams a day, not 325. Clopidogrel, 75 a day for somewhere between 1 and 12 months. Beta blockers, all patients without contraindications, but titrate the dose carefully in patients with heart failure. ACE inhibitors or ARBs, especially in patients with heart failure and LVEF that's impaired, hypertension or diabetes, and again, titrate the statin, ideally to an LDL less than 70. Do I have time to do this, or no? I don't have time. Okay. Just wanted to mention that I added a couple of slides. These will be on the website. That we tend to overdose patients with these drugs, and that results in bleeding. And the slides I showed you show that bleeding leads to death. And so this is the definition of overdosing in this paper in JAMA. Low molecular weight heparin more than 1 milligram per kilogram, heparin more than 70 units per kilo, and then tirofiban eptifibatide. And you can see here that we do especially poorly in older patients and overdosing them with these drugs. And in dialysis patients, we also don't do well. This is a large study of dialysis patients. 22% received a contraindicated medication. Some got enoxaparin, which is contraindicated. Some got eptifibatide, which is contraindicated. And some got both. And when they got the drugs, they had a higher risk of bleeding and a higher risk of death. So do not give enoxaparin or eptifibatide to dialysis patients. And read your journals. Okay.